And last but not least, it's my pleasure to introduce Dr. Swartz. Dr. Swartz is a clinician scientist in the Department of Medicine Neurology at the University of Toronto. He works as a stroke neurologist, directs the Sunnybrook Stroke Research Unit, and is medical director of the North and East GTA Regional Stroke Program. His clinics focus on complex stroke causes, including stroke in young adults, vasculitis, and pregnancy, and he has co-chaired the development of heart and stroke consensus statements on stroke and pregnancy. Thank you.
Thank you very much. I have no commercial or conflict of interest statements to declare, so I'm going to dive right into stroke and pregnancy, but I do have a couple of potential biases to highlight. We are going to be discussing off-label uses of drugs because there's very little randomized controlled trial data evidence of the management of stroke in pregnancy, and I will use a Simpsons image. We're going to be going over in the next few minutes an incidence and overview of stroke in pregnancy. We're going to be talking a little bit about the consensus process and the consensus statements, and I'll give a little bit of insight on some of the things that aren't yet out in the consensus documents. So first of all, I'm going to start with my audience response questionnaire, but we're going to do it old school. So how many people have actually seen or managed a patient with stroke? Excellent. And how many, see how fast that was? We don't need technology. And how many people in this audience have managed a patient with pregnancy? Excellent. And how many people have managed a case of stroke or acute neurological symptoms in pregnancy? And headache in pregnancy? So excellent. So we have a lot of overlap and a fair number of people have actually seen these kinds of cases. So just to set the stage for a minute, stroke in pregnancy is relatively rare. If you're an obstetrician or a stroke neurologist, you're probably going to see it. If you're a primary care clinician, it depends how much obstetrics you have in your practice. But it is a major cause of morbidity and mortality during pregnancy and postpartum, and it's actually the big driver of the morbidity and mortality from the big, at least in worldwide, the biggest problems in pregnancy. So the hypertensive disorders of pregnancy, preeclampsia and eclampsia. What causes the morbidity and mortality of eclampsia is essentially stroke. It's bleeding. Overall, stroke in pregnancy has, like stroke outside of pregnancy, higher mortality and morbidity for bleeds than for ischemic strokes. And for those of you who have pregnant patients in your practice, may be pregnant or have partners who are pregnant, the absolute risk is low. So this isn't something that's sort of reflected in the audience response questions. This is not something that happens that commonly, but the relative risk is increased. Pregnancy is a high-risk time for clots to form, and clots to form in the brain as well. But the incidence estimates have actually varied fairly significantly. So one of the things that we wanted to do, and I'll tell you a little bit about that work, is to try to see if we can get better estimates of the incidence of stroke in pregnancy. In general, stroke is broadly divided up between ischemic stroke, hemorrhagic stroke, and venous sinus thrombosis in pregnancy. All of them occur, and venous sinus thrombosis is one of these overlap syndromes because people can present with venous hemorrhage. So you can have a venous sinus thrombosis and an intracranial hemorrhage at the same time. The risk is actually the highest immediately peripartum and up to 6 weeks postpartum. And some of this is physiologic, and some of it is actually biased by indication. Because when a woman's blood pressure goes to 180 and she's pregnant, we deliver her. And when a woman has focal neurological symptoms and signs of a stroke, she might be, if she's especially in the third trimester, we will trigger delivery because of concerns of eclampsia and preeclampsia. And so, of course, immediately peripartum, there is a higher risk of stroke in that setting because we deliver people if they have a stroke in the third trimester. But a lot of this is also physiologic because that's when the clotting factors are their highest. That's where the blood pressure spikes are the most common, where risks of peripartum angiopathy also go up. So I'm going to talk about that again. This is our attempt to really get through to the better numbers of the incidence of stroke in pregnancy. And so this just came out this fall in the International Journal of Stroke. I'm not going to go through in detail the methodology, but we undertook a systematic review of the literature to try to see, can we really quantify how often this happens? And the answer is yes. We came up with numbers. There's still a lot of variability, as you can sort of get a sense from the plots from the published papers that are there. Overall, the number to keep in our heads, it actually was handy that it came out to a nice round number. It's easy to remember. We didn't even round it off. This was the point estimate, 30.0 per 100,000. Makes it easy to remember. And conveniently, the point estimates for stroke in young adults, age 18 to 44, are about 10 per 100,000. So we're talking about a 3 times relative risk. The absolute risk, though, is still very low, 999,970 people get through their pregnancies just fine. It's the 30 that have the stroke that we're talking about. So it is an increased relative risk compared to not being pregnant, but the absolute risk is still quite low. We didn't see any effect of trends over time, including one of the papers I just want to point out by Cheryl Jacobin from the year 2000, using Toronto and Ontario data. And so when we look over time, there wasn't a trend increasing or decreasing. There's a lot of variability in the types of studies that are included here, including some very large population studies and from the Get With the Guidelines program in the United States, as well as single center retrospective case series where they would go and pull chart reviews from the thousands of pregnancies that they've delivered over the last X number of years and identified the pregnant cases to get incidence estimates. One of the most interesting areas that we found was a change and variability by health system. And so this was not anything we could put a statistical significance to, but we did notice a bit of a trend that recent population level data from Canada, from the UK, and from Sweden, all areas with a large publicly funded healthcare system with primary preventative care in pregnancy, had lower estimates than especially the Midwest US, but even overall the United States and other countries with less primary preventative care. Why is it that pregnancy carries an increased risk of stroke? Well, there are common underlying etiologies that can be destabilized. So aneurysms and AVMs, the vascular endothelium, can change in pregnancy, so pregnancy can make them more prone to rupture. Things like gestational hypertension, HELP syndrome, preeclampsia, and eclampsia are more common. Obviously, some of these are gestational by definition, so they occur in pregnancy and they increase the risk of stroke. And then underlying risk factors that can be increased in pregnancy include gestational hypertension, gestational diabetes, thrombocytopenias, and then the more typical, we heard a bit about migraine already, and then pregnancy-specific issues like dehydration, prothrombotic changes, volumes of distribution changes, hypertensive disorders, the peripartum and postpartum angiopathy, which are now kind of enrolled under this broader clinical syndrome of RCVS, which stands for reversible cerebral vasoconstriction syndrome. Pregnancy is one of the triggers for RCVS. Triptans and migraine medications are another one. Ergots are another one. Marijuana is another one that is increasingly common and not that well recognized by people, as are Sudafed and over-the-counter decongestant type drugs. So a lot of different triggers, and venous sinus thrombosis, obviously. We noted really a third. It's a nice convenient medical rule of thirds, the distribution between ischemic stroke, hemorrhagic stroke, and venous sinus thrombosis. 12, almost exactly the same between hemorrhagic and ischemic. And if you look at stroke overall, outside of the context of pregnancy, which is very heavily weighted towards older populations, generally speaking, hemorrhagic stroke represents around 15, maybe 20%, depending on your population. So in pregnancy, there's a lot more bleeding stroke. In general, in young adults, even outside of pregnancy, there is more bleeding stroke proportionally. So this is sort of fits with both the pregnancy-specific and the fact that young adults are a little less prone to clotting strokes as a group than older adults are. But venous sinus thrombosis is right up there. And if you look at the range of the estimates, it's roughly in the 10 per 100,000 of each, adding up to our 30. So as we saw, again, by our raise of hands at the beginning of the talk, high volume stroke centers, high volume obstetrical centers, those with busy obstetrical or stroke practices will encounter patients with stroke in pregnancy. But most clinicians, if they see any, see only a few. And each case is different. Did they have a stroke at some point in their history and now they want to become pregnant, or they show up in your office pregnant? Did they have an uneventful pregnancy until 2 weeks postpartum when they developed preeclampsia and had a stroke? Those are very different scenarios with very different considerations. Did they have a very mild stroke, maybe a migrainous infarct with a little bit of occipital abnormality on their MRI, but functionally they're totally fine? Or is this a woman with a disabling stroke who needs assistance with activities of daily living and needs help to care for her baby? Again, very different issues, very different considerations that come into play. There are excellent grade A recommendations for best practice guidelines in stroke management, and hopefully you've heard of those. There are the American ones, and then our Canadian best practice recommendations are very searchable and Googleable, and I would encourage you to look at just Google Canadian stroke best practice recommendations. We have a lot of recommendations for prevention and acute management of stroke. Similarly, the obstetrical world has lots of recommendations for the management of pregnancy in general. But there's very little guidance on how we handle when the two worlds collide. And how do we approach these seemingly one-off patients? Is there a way we can bring some order to the chaos theory that we have pictures of there? So I like to think there is. I like to think, like a lot of neurology, the approach is really important. And so the first thing is to keep in the back of your head that maternal health is absolutely vital for fetal well-being, that we can't trade one for the other. We need a healthy mother to get a healthy baby. The next major consideration that we encourage people to ask is to stop and think, how would we treat the patient if she wasn't pregnant? So if we're dealing with a stroke patient, either a hyperacute stroke and we're thinking TPA and endovascular therapy, or secondary prevention and we're thinking antiplatelets and statins, the first question is, what will we be doing if she wasn't pregnant? And this may be more of a question for either primary care clinicians or our obstetrics colleagues who are managing them than for the stroke neurologists, but how would we manage the pregnancy if she hadn't had a stroke? We want to start with those as our foundations and then nuance accordingly. And we nuance with these kinds of questions. And this is a sort of general approach to the management of neurological and other disorders in pregnancy, right? How will the pregnancy affect having a stroke? How will the disease affect the pregnancy and the fetus? And the good news is a stroke in the mother will not affect the fetus. It's the underlying cause that we have to be concerned about. So the hypertension or the antiphospholipid antibody syndromes or things like that. How will the treatments affect the pregnancy and the fetus? And then what do we need to think about to nuance plans for labor, delivery, anesthesia, breastfeeding? A team approach is essential, planning is key, and we do need to individualize based on a whole lot of factors. And so how do we boil this down and make this something usable for people? Well, we went through a consensus building process because a guideline or a recommendation requires high-grade randomized controlled trial type evidence that's directly applicable. This is not that. We don't have 1,000 patients or 16,000 patients with hormone replacement who have had, in this case, we don't have 16,000 patients who have had a stroke during their pregnancy on whom we have done randomized controlled trials. And all of the stuff that I just showed you with the differences in etiology between hemorrhagic, ischemic venous sinus thrombosis, the different stages of pregnancy at which the stroke would occur, or even if it's a stroke before the pregnancy and now they need prevention advice, all these different issues make it very difficult to get a homogeneous group of people for a clinical trial. So the best we can do is figure out how do we apply the evidence from the stroke world and the evidence from the obstetrics world to the patient in front of us. And for that, we underwent a rigorous, formal Delphi building consensus process. And our language is from a consensus statement. Ought to consider, should consider, could consider, may be offered. There's not going to be a lot of musts and shoulds because we don't have the randomized control trial data. This is, the consensus statements really reflect stroke experts from around the country and international experts in stroke in pregnancy, stroke in young women with Andrew James and Cheryl Bushnell, who have published a lot on this, as well as obstetricians, high-risk OBs, obstetrical anesthesiologists, it's a mouthful, maternal fetal medicine specialists, and we really try to have multidisciplinary representation within this group. And as I mentioned, we had this multi-modality multi-phase, starting with systematic reviews of the evidence that we have from both stroke and obstetrics, and then starting to generate where do we find agreement, what can we all stand behind, and what do we need to raise as other considerations, and we iterated this through the Delphi consensus process. We talked about two different groups. I always joke that as a stroke neurologist, I tend to see pregnant women who get neurology, whereas my colleague Esther Bowie, who is an epileptologist, sees neurological patients who want to get pregnant. And so the women with epilepsy issues are more about the prevention and the management of the pregnancy. In this case, though, we also looked at it from both of those lenses. We divided the consensus statements into two groups. The first is the women with neurology, women with a history of stroke who now want to get pregnant or come into our office and are pregnant. And so this is really all about secondary prevention. And a lot of the recommendations then have to be nuanced by what did they come to you on? If they find out they're pregnant or they want to get pregnant and they're taking Plavix or aspirin or statin, what do we need to do? How old were they when they had their stroke? What type of stroke did they have? Is this a pre-pregnancy consult, or are they actually sitting in front of you at 23 weeks? Very different considerations based on the stage of the pregnancy to consider. The second group of patients are the ones with really more acute management of stroke, nuanced by the pregnancy. So these are more typically third trimester or postpartum patients, but I have seen a number of patients in the first or second trimester who experience a stroke. And then there's similar but also different considerations. How bad is the stroke? How worried about? Are we worried about their airway and breathing and level of consciousness, or are we worried about, are they walking and talking and this was a migrainous infarct? I did actually have a patient in her third trimester who was having recurrent migrainous infarction near the end stage of her pregnancy without any preeclampsia or eclampsia or blood pressure issues. Her issues are very different from somebody with an acute disabling stroke in whom we might be thinking about endovascular therapy, for example. So we were trying to really bridge these two worlds, and we have two different publications that will address this. The acute stroke paper is actually still undergoing the Delphi process, and so I'm not going to be able to talk about the recommendations from that, although I will give you some of my own personal views on the imaging issues. We were really focused, I'll show some of the recommendations from stroke prevention. But for the things that we go through quickly, if you're interested, these were just published a couple of weeks ago, 2 weeks ago now, in the International Journal of Stroke. Conveniently, they were published in the same issue as the Canadian Stroke Best Practice recommendations in general for primary prevention of stroke. So in the same issue, you can download both. They're all there. And so we have general secondary stroke prevention, and then we have stroke prevention in pregnancy. So it's good press. When you look up one, you look up the other, which is great. It also gives some context, because we're really not talking about all the things you do for stroke prevention in this. We're really referring to how do we need to nuance it in pregnancy. And I'm going to encourage you, I'll just highlight one issue that we raised earlier that Dr. Lay raised in the PFO discussion. So PFO is not recommended as a guideline recommendation for the treatment of migraines. It's actually as of 2 weeks ago, it's made it back into the Canadian Best Practice recommendations for the secondary prevention of stroke based on several long-term follow-ups from the PFO closure trials. And so for select patients, and I won't go through the statement in detail, but for specific patients, cryptogenic stroke, young adults with no other causes of their stroke in whom a PFO is found, PFO closure now has evidence that 5-year and 10-year stroke risk may be reduced. So if you're interested in that, I'd encourage you to see the guidelines on general secondary stroke prevention. These are the major topic areas that were considered, and I'm going to sort of highlight a few of the key consensus statements. The first is we really don't have good evidence for antiplatelets other than aspirin. Aspirin's been around for going on 150 years now. I've lost track. I don't even know. But it's been around for more than 100 years. And we know what aspirin does in pregnancy. And we have multiple randomized controlled trials showing that aspirin is very safe after 11 weeks of pregnancy. We don't know as much about it preconception and before pregnancy is known, but there are a couple of clinical trials now that have emerged, randomized controlled trials, showing safety of aspirin, even preconception and in very early first trimester. There have been theoretical risks raised of early aspirin exposure that are not borne out in those clinical trials. The American guidelines are still very circumspect about this. Our Canadian consensus panel actually says if we have a woman in whom we feel aspirin is indicated, if you think they had an ischemic stroke and for a cause that's not been identified and reversed, and aspirin is indicated, that we should be considering aspirin even preconception. We want to avoid warfarin, especially in the first 6 to 12 weeks. We have no data whatsoever on the direct oral anticoagulants. We really don't know what they do in pregnancy, so those are not preferred. And if we need anticoagulation, if it's after the first trimester, you could consider warfarin, but more generally, low molecular weight heparins are the option of choice. For hypertension management, I would defer. For routine hypertension management, defer to existing guidelines on the management of blood pressure in pregnancy, but specifically for stroke patients, for all women in pregnancy, we avoid ACEs and ARBs. Those are very commonly used in stroke prevention, so I just want to highlight that. And the 3 agents that we have the most safety data on in pregnancy are labetalol, Adalat, or long-acting nifedipine, and methyldopa. So those 3 are the big 3 that we use. So in some ways, pregnancy simplifies our drug repertoire. We got aspirin, we got low molecular weight heparin, we got labetalol, Adalat, and methyldopa, and those are the kinds of things we do. We do not bother measuring lipid levels in pregnancy. They're unreliable, so we don't know what they mean. We don't know what the targets are, so don't even look. Would be my preference. And we don't have solid enough evidence to know that statins are safe in pregnancy. And so given that statins are really about the long-term risk reduction, 50 patients for 5 years to prevent 1 stroke in the Sparkle study, a 9-month interruption is considered, or a 1-year interruption is considered reasonable. And so we usually avoid statins. And PFO closure, well, it is recommended now for certain patients in general secondary prevention. During pregnancy, we don't have safety data on PFO closure, so we don't do that. I'm going to depart from the consensus recommendations because, as I mentioned, the acute, so the imaging, the TPA, the endovascular, those kinds of things, those consensus statements are not yet ready for release. I will tell you my personal management, and these slides predate the consensus recommendations. CT scan is safe in pregnancy. A CT scan represents ionizing radiation, but it's of the head. We can shield the abdomen and pelvis. There's that inverse square law from back in our physics days that tell us the further you are away from the source, the less radiation you get. Fetal radiation exposure from a plain CT head is less than 0.05 centigrade. That's less than 1% of the max tolerable fetal exposure dose. So if you have a woman with a sudden severe headache, a disabling neurological deficit, something that is significantly changed, an emergency room worthy presentation, a plain CT head is absolutely reasonable and can be acquired quickly. If you're in a place where you can get an MRI, I'll talk about that in a minute, more power to you, but a plain CT head, pregnancy is not a reason to avoid a plain CT head. We do try to avoid iodinated contrast, so not a contrast-enhanced scan, not a CT angiogram or a CT perfusion. In MRI, there were theoretical risks raised, but the bottom line here, and I'm going to refer you to a paper by Joel Ray from Toronto in JAMA of 2016. This is a great paper where he looked at Ontarians, more than 1 million Ontarian pregnancies, and looked at first trimester MRI exposure and first trimester GAD exposure. In the first group with first trimester plain MRI, no increased risks in stillbirth, death, congenital abnormalities, neoplasms, vision, hearing loss, anything. So even first trimester MRI are considered safe and reasonable. But again, we would avoid contrast. Gadolinium did increase the risks of stillbirth, death, and a catch-all group of any rheumatological, inflammatory, or infiltrative skin conditions. So if you have a woman in pregnancy presenting with an atypical migraine, severe thunderclap headache, or focal neurological deficits, which are common symptoms of visual auras or atypical auras, you can with some confidence offer a plain MRI in pregnancy, especially if they're in the second and third trimester. But even in the first trimester, we now have evidence of safety. Gadolinium doesn't cross into the breast milk very much, and even less of that that's in the breast milk gets into the baby's system through their own GI tract. And so gadolinium is considered reasonable for breastfeeding women, although they can also pump and dump if they have concerns. So overall, the philosophy of treating a pregnant woman with stroke is probably the most important thing to take, because individual cases must be individually treated. But we want to make sure that we keep that idea in mind. We need a healthy mother to get a healthy baby. We do need a team approach. We have to consider a lot of different factors when we're nuancing our treatment decisions and considering all of these different variables. We want to understand and remember how we would treat stroke if she wasn't pregnant, and how we would treat the pregnancy if she didn't have a stroke, and then nuance accordingly. That's where the team approach is really helpful. Planning is very important, and individualized management. Thank you very much. I guess I have the prerogative of leaving the question slide up because I'm the last one, right?
Well, thank you very much for very informative presentations. We now have about 30 minutes for questions, and there's microphones on each side of the room, and there's also pen and paper on your tables. If you want to write down some questions and hold them up, somebody will come and pick them up and bring them up here. There's a question there. Just while they're bringing the questions up, I'll also remind you that there is a dinner symposium here at 6 o'clock tonight in this ballroom, and the topic is hot topics in atrial fibrillation.
So, first of all, let me thank you for an excellent presentation. It's quite loaded with the information that you provided today. One interesting question that came across was perhaps the use of aspirin, both in those patients who have migraine with aura, where the risk of stroke is increased if they are less than 45, and in those women who may be taking HRT. Is there any support for that?
No, there is no support for HRT use. You're asking about the women who are premenopausal or postmenopausal? Perimenopausal, right?
Yes, yes.
No, there is no, especially for migraine treatment. I don't think there are any benefits. The studies that I mentioned really looked at chronic disease, but I think there is an increased risk of these chronic diseases, and I would not use it for migraine treatment.
I think many of the migraine patients you see are going to be perimenopausal. They're struggling with the vasomotor symptoms. So what we found to be very effective is something we kind of borrowed from the gynecology folks, and that is completely off-label use of gabapentin and sertraline. And those are drugs that are often helpful in managing a migraine, who's a migraineur who's got too many attacks, sort of as a prevention, and they're quite effective for controlling the vasomotor symptoms. And then we do a lot of teaching around sleep hygiene and trying to get sleep into a good place. So we rarely ever say, yes, you know what, why don't you try HRT for those symptoms in those cases?
I have a subsidiary question, if I may. So majority of us are family doctors. And it's very interesting that our peer body, the SOGC, seems to be rather soft on the use of HRT. If you look at their policy statements, and you can go, they've done it 3 times. The first one came after uproar following WHI study, and everybody was scared of, and the media was broadcasting that. Then subsequently, they did it again in 2009 or so, and then 2014. At all times, it seems to take a soft stand that you should address the quality of life. Now, as physicians, of course, we feel very sympathetic to our women's symptoms, but we cannot risk their lives. And then, of course, CBC takes this over. Christine Barak, she's very good at broadcasting. And then the patients come to the office and say, this is what I heard in CBC. So perhaps you can answer those questions.
Sure.
Thank you very much.
So the question is, is there any role for HRT? Because some guidelines do recommend it. And I've seen these guidelines, but they're they're not clear on duration. They say for the shortest duration possible, sometimes less than 5 years, less than a year. And again, in someone who has no vascular risk factors, I think it is reasonable to think about maybe a transdermal formulation of estrogen for a very short period of time. In my practice, most women have had a stroke, so I'm really reluctant to prescribe it. But I think if it's a healthy person, without, and it is the only thing, if Dr. Lay's recommendations and those medications and sleep hygiene are not working for a very, very short duration, potentially not the oral formulation, but transdermal and vaginal may also be beneficial. But and again, in a younger woman, I do have some patients who are in their 70s and 80s who, still would like to be on this. I think short period, close to menopause, transdermal or vaginal formulation for the shortest period possible, if someone really is having disabling symptoms.
Sorry, I was just going to make a comment on that. In a migraine patient, doesn't relate to stroke, but these women who do go on that form of HRTs, for instance, a vaginal, they really have to be taught that they have to change it every 3.5 days in a week, not twice a week. Because if they change it Monday morning, Thursday morning, Tuesday morning, Saturday afternoon, they're at risk of getting these subtle but real changes in estrogen that's in the bloodstream, and it seems to trigger more headaches. So just as an aside point. No.
There's another question here.
Yes, thank you very much. Thanks for your talks. I just wanted to confirm what you said about the risk of stroke for Dr. Lay, I guess, in being higher in migraineurs with aura in women under 45. Is that independent of sort of epidemiology of OCP use? Because it just seems contrary to what I always thought 40 and over is where the risk in your OCP patients comes in of stroke, cardiovascular disease, et cetera.
Even in the younger patients. So if you look at the risk, it's maybe 1 in 10,000, but a migraineur who has aura and is under 45, 2.5 times that. So 2.5 women there. Still, it's a relatively small risk still, but then you're doubling it. And so even that woman who then goes on a birth control pill and she's 43, she has that increased risk of stroke. The same applies after age 45 with smoking and birth control pill use, of course.
So being over 45 doesn't mean your risk suddenly goes down?
No,
it just,
absolutely. It's just almost like you're getting to the higher risk sooner as a younger person with migraine with aura, and you kind of catch up earlier. Yeah.
All right, we have a question that was raised here. Are migraines associated with cognitive decline, given that MRIs are showing non-specific white matter disease associated with migraines?
So fortunately, it looks like no, but do we really understand what the white matter changes are? We don't fully understand. There's a little bit of very recent literature suggesting that if you can really encourage your patient to adopt a healthy lifestyle, to take a preventative medication to reduce their migraine burden, so frequency, severity, duration, and to treat the attacks rather than letting them go on unmanaged for 72 hours, you can actually see some improvement in that white matter burden. So there is a plasticity to this. There seems to be some change. The thing I talked about with my patients far more than sort of migraine being a risk for cognitive decline is their sleep, because we do have good evidence that poor quality sleep is a risk factor. And so a lot of migraine patients get stuck in poor sleep. They're waking in the middle of the morning with a bad attack. Often they're not sleeping well, or they have very bad sleep habits. It's creating more migraines for them. I also talk to patients about the fact that the average medium of one of our very popular coffee chains that came up from the States, a medium has the same amount of caffeine as 9 cans of Coke. Mm-hmm. And people don't realize how much caffeine they're consuming, and then it leads to all the sleep trouble. So I think it's the other factors we talk about cognitive decline more than the white matter change.
And I'll just throw in there that you have common underlying etiologies. So obstructive sleep apnea is a risk factor for stroke. It's a risk factor for cognitive decline. It's a risk factor for white matter hyperintensities. And it's a risk factor for symptomatic sort of fuzziness. And so sleep studies in addition to sleep hygiene and caffeine avoidance and those kinds of things. Undiagnosed sleep apnea is a key player, I think, in our stroke clinics, in our migraine clinics, and in primary care.
Even in slim women. They don't have to be an overweight man, yeah.
Okay, we have another question. What is your recommendation for use of hormone replacement therapy in menopausal women with migraine with visual aura?
Yeah, I think we just addressed that a couple of minutes ago, and I don't typically recommend HRT in those patients. Maybe, as Dr. Jageman was saying, if they really need something, they failed other methods, herbal methods, or other medications to control those symptoms, then you might think about perhaps vaginal HRT. But we don't send people off for HRT, peri, post-menopausal migraine with aura for sure.
What blood work do you order to assess hypercoagulability?
So in our Stroke in the Young clinic, usually, I guess it depends a little bit which type of hypercoagulability you're looking at. So as we were talking about with pregnancy, if you have someone with a venous sinus thrombosis, then there's a whole lot more that we would test for. If you're talking about ischemic stroke only, then we're talking about arterial hypercoagulability, and there you're really looking at the antiphospholipid antibodies. So antiphospholipid, anticardiolipin, lupus anticoagulant, sometimes beta-2 glycoprotein. Those are the ones that are associated with arterial hypercoagulability. The venous or PFO, paradoxical emboli type strokes, that would be a whole other set of hypercoagulable factors. So factor V Leiden gene mutation, prothrombin gene mutation, or some people call that factor 2, protein C, protein S, antithrombin 3. Those are the typical venous hypercoagulable workup. And then certainly in my clinic, depending on the symptoms, if you have other findings, we often will do some autoimmune inflammatory screening, because even in the absence of antiphospholipid antibody syndromes, lupus, Behçet's, other inflammatory diseases can have CNS involvement, which can increase risk of ischemic stroke or stroke-like lesions on the scans.
The only thing I would add is sort of as a neurologist, if I see a patient, I think, wow, I've been asked, can this patient take a birth control pill? They have migraine with aura. I've discovered they had an uncle with a PE and their father had a DVT, or mother, I'm thinking, gosh, there's something here. I wouldn't just sort of randomly order some things. I usually recommend back to the gynecologist or the family doctor that person see a hematologist for a good solid opinion around what is a reasonable lab to order, because just as Dr. Swartz is saying, it really depends on what you might be looking for, what you're going to order.
It's a little different when they've had the stroke.
Absolutely, if they've already had the stroke, yeah. It's pre-stroke is different, yeah.
Okay, we have another question here. Given the association of PFO and migraine and with stroke, should we be screening patients with migraine for PFO?
So it depends which side of the table you're on. If they've not had a stroke, they've got migraine, no. But just as Dr. Swartz said,
so if it's a young adult with a stroke and no other cause, and they don't have atrial fibrillation, and they didn't have a dissection, and you don't have any other source, and there's no family history, and they don't have Ehlers-Danlos or other obvious causes of stroke in young adults, then yes, we often do an echocardiogram. Or actually, we do an echocardiogram as part of the guidelines, and potentially even a transesophageal echocardiogram to look for PFO. But as far as migraine prevention, no.
And I think a lot of patients will come in and ask you about this, so it's good to have a little bit of information to say, well, yes, I know it's out in the literature and you've read about this, but let me talk to you about why we do need to consider it or don't in a strictly migraine person.
There's a question here.
Dr. Lay, can you share any more details about the newer medications for prevention of migraine?
Sure. So these are in a class. They're called CGRP blockers. And calcitonin gene-related peptide is a vasodilator that is diffuse. It's in the body everywhere. And over 10 years ago, probably, there was some development of these drugs. And one of them looked exceptionally promising. And the company found it was really a great drug for acutely aborting a migraine, decided to test it in an RCT for prevention, and there were liver problems, so that drug died. But the science behind it did not die, and now what has come, there are 4 different agents that will be hitting the market in 2018, 2019. The first one will come to the Canadian market probably in August of 2018. They are monoclonal antibodies. One of them is a fully humanized, the other 3 are partially humanized. One of them is a receptor blocker of CGRP, the other 3 actually block the CGRP themselves. But in terms of efficacy, they look rather promising. 3 of them are self-injection once a month at home, and one of them is an intravenous once a month. There are super responders. 16 to 20% of patients after 1 treatment have no more migraine. In the studies, they kept taking the drug, so we don't know if you stopped it, would they go back? That's something that will come in real-world practice. About 30% of patients had a 75% reduction in migraine, so if they had 20 attacks per month, now they have 5, and 50% had a 50% reduction. But extremely well tolerated, no downside. The efficacy is seen in the first week, so they sound phenomenal, but we have to wait for real-world practice to see, are there other problems that are going to crop? Are there other things we have to think about? So the main reason they look promising is based on science. Besides their efficacy, they don't seem to have any arterial issues. And one of the companies, very bravely, it was done in Europe, it would never pass REB in North America, but they took people who had known coronary artery disease, known angina, and they put them on a treadmill and ran them till they got ST changes. And then they gave them the drug, and then they ran them on the treadmill and found that the ST changes were no different in terms of significance and timing. So they look to be pretty good.
Okay, we have another question here. Should we still use beta blockers to prevent migraines, and what other meds are safe in females less than 45 with aura?
So yes, we use a lot of beta blockers in migraine prevention for sure, but I don't use them in patients who have aura. I sort of avoid them as a class per se in a migraine patient who has aura. So while a lot of physicians are comfortable prescribing propranolol, for example, in migraine patients, and a lot of patients get good efficacy from it, we generally don't, in the headache field, recommend it for a patient who has aura.
I'm going to throw one out there for you. There was a not very well done clinical trial of melatonin for the prevention of migraines. So part A would be to just comment on the use of melatonin and other sort of natural therapies, so riboflavin and magnesium and those ones. And the second would be in the setting of pregnancy, to bring our talks together. What options do you like to list?
So I use a fair bit of melatonin, and it can be efficacious even if the person isn't having trouble sleeping. There's a little bit of science. If you look at the melatonin chemical ring structure, it shares a lot in common with indomethacin. So we think there may be some anti-inflammatory benefit, and it's quite easy on the stomach. So we use a fair bit of it, even in people who don't sleep well. I am a huge proponent of non-drug therapies in patients. They come into 2 categories: vitamin therapy and lifestyle therapy. So in vitamin therapy or herbals, we've had very good efficacy with magnesium, particularly magnesium citrate. I know the other forms of magnesium are often better tolerated, but the evidence is around magnesium citrate. Vitamin B2 riboflavin, you escalate to a dose of 200 milligrams twice daily. It works best if it's split rather than once a day. CoQ10 also has good randomized evidence at about a dose of 300 milligrams. Butterbur has great evidence. That's a natural anti-inflammatory plant that grows mostly on riverbanks wildly. Do not eat the plant off the riverbank because it's full of carcinogens. But if you pharmacologically manipulate it, it can be quite effective. It fell off the map about 2 years ago because there was a very small study in Germany with 1 or 2 patients that had liver issues. That has since borne out and not proven to be true in good quality Butterbur purchased in North America that is PA-free, because that's the carcinogenic part of it. But we use lots of herbals. Lifestyle part, good hydration, not skipping meals. If you're going to eat, fresh is better than frozen, and frozen is better than canned. We ask patients to avoid additives, preservatives, colors. If you pick up something and it's red and it says natural red color, there's a very good chance that comes from conchyla, which is bug juice, beetle juice. It's a headache trigger for migraine patients. So we ask them to read labels, and sleep is probably the biggest thing we spend time on with patients. We do a lot of CBTI for insomnia. Patients often get sleep studies. We're doing a study right now looking at sleep in patients. So when you take it over to the migraineur, every migraine patient I meet who's female, unless she's postmenopausal, I say, look, if there's any chance of pregnancy, or you think you're planning, or you might like to have children, let's talk, but here are the basics. So before they get pregnant is the time to start managing the migraine better. I try to get women off caffeine, because when they're pregnant, they can use a low-dose caffeine acetaminophen combination and get a very decent result. I don't have them drink ginger ale when they have nausea in pregnancy, because ginger ale has sodium benzoate in it and tends to trigger headaches. Same as some of the sports drinks and others, there's often a lot of preservatives and additives. So a lot of it comes in pre, and a lot of it is when they're pregnant. So magnesium, we used to use quite freely in pregnancy, and now we're backed off a little bit. We go either with none or a very low dose. So outside of pregnancy, a patient could be on 450 to 600 milligrams. In pregnancy, we're down around 100 milligrams now, once they find out they're pregnant, to back off. Anything else you use? Or no?
A lot of the same stuff.
Yeah, same stuff, yeah.
Sometimes about
Yeah.
I have a question for Dr. Yagapan. Would you recommend hormone replacement therapy for someone who's had a previous stroke?
No, definitely not. I think given the evidence, if they've had a hysterectomy or not, I think there is an evidence there's increased risk, so no.
I think
That's it. Well, I think we're done.
I think there's one more question here.
I think you had mentioned in one of the slides that you could use ACE inhibitors, statins, and vitamin D for migraine prophylaxis. Would
Yes.
you please be able to comment on those three?
So Candesart and Atacand is actually got very good evidence according to the Canadian Headache Society guidelines in terms of its efficacy in migraine, for migraine prevention. While you might use a higher dose in for blood pressure issues, for the headache dose we tend to start at the lowest, which is 4 milligram. Even some people will use a half. But there's the caveat there, the vast majority of migraineurs are young women who could get pregnant. So just as we learned from Dr. Schwartz's talk, this is not a good choice in someone who there's any chance of pregnancy. The other study that was just released a little while ago or recently was on simvastatin and vitamin D, 2,000 IU of vitamin D and simvastatin. I think it was standard dosing. But they randomized controlled trial, and patients had benefit in migraine prevention. The theory behind it being there probably is some kind of endothelial something that's improved. So those are two newer options that a lot of people don't know about.
So that was independent of their actually having hypertension or elevated cholesterol, correct?
Exactly.
Okay.
Yep.
Thanks.
Okay.
Okay.
I
Thank
don't
you.
think there's any other questions, so on behalf of the Planning Committee and the delegates, I'd like to thank our panel for such an interesting presentation and discussion. Thank you very much.